The Community Memorial Health System Speaker Series Online is brought to you by Mission Home Health. Mission Home Health and Hospice is committed to taking care of people by providing the highest quality, cost-effective care wherever the patient calls home. With over 14 locations, Mission delivers skilled home health, hospice, and palliative care services to more than 3,000 patients a day. As a preferred partner with several health systems, Mission works with providers to customize each partnership to provide exceptional coordinated care. Visit our website to learn more at www.homewithmission.com. We take care of people, and one call does it all.
Good evening, and welcome to the online speaker series at Community Memorial Hospital, The Road to Recovery. We're from the Outpatient Rehabilitation Program here at CMH. My name is Scott DeAngelis. I'm one of the licensed and registered occupational therapists. I specialize in neurological recovery, and I'm working towards specialization in visual perceptual disturbances and visual perceptual training. I'm also joined by my colleagues, Christina and Dina, and they'll introduce themselves now.
My name is Dina Taryn. I'm a senior speech language pathologist at Community Memorial Hospital, and I specialize in feeding, swallowing, speech, language, voice disorders from a variety of different diagnoses here at CMH.
And my name is Christina Malone. I'm a doctor of physical therapy, a certified strength and conditioning specialist, and a licensed LSVT BIG practitioner. So today we're going to be telling you a little bit about our outpatient services, as well as a new program that we are introducing to the community. So first off, we are a full service rehab department. Our hours are from 8 a.m. to 5 p.m. and we accept almost all insurances. All appointments are one-on-one with a licensed physical therapist, and you have at least 45 minutes. So that means you'll never be passed off to an unlicensed person to perform exercises or do anything else. And that really makes us a unique asset in the community. We offer physical therapy, occupational, and speech therapy, as well as options for telehealth. And we treat all diagnoses, so that includes orthopedic, post-operative, and neurological conditions, which we'll be focusing on today. So a little bit about what physical therapy is. So physical therapy services are provided by a licensed physical therapist. It includes an evaluation, an assessment, and treatment for individuals with limitations in functional mobility. So this can include bed mobility, getting in and out of bed, walking, transferring, so getting up from sitting to standing positions, or returning to work or sport. Physical therapists are trained to assess conditions and help patients regain the maximal amount of functional mobility that they can. And also independence, and we use evidence-based practice. So treatment is very personalized to each individual's abilities and goals, and we really sit down with each person and see what they want to get out of their physical therapy experience.
A little bit about occupational therapy. So what is occupational therapy? Well, it's more than the name may imply. Many times people may think, oh, well, I'm retired or I'm of a certain age. I don't work any longer. But occupational therapy and occupations in general are not just those things that we would do for a vocation or paid employment. Rather, they are things that are meaningful to you, everyday activities, everyday tasks and routines. And that's what we focus on. OT, or occupational therapy, is an evidence-based practice that promotes a holistic view of the individual. We take into account the dynamic interaction between internal and external factors that affect your abilities to perform daily tasks. We often, like I said, we often use person's routines, their roles, their habits, rituals, and overall the person's identity as a central focus for motivation and participation in the rehabilitation process. So again, the activities or occupations that we focus on, they're meaningful, and they're generally activities of choice, things that you would like to do, or necessity. So that's a myriad of activities, right? So that can be anything from getting ready and dressed in the morning to making breakfast, to checking your email, to making a schedule for the day, to driving, to gardening, fishing, you name it. That's kind of what we're focusing on. And we're going to try and use some of those activities as they are, or we may use other treatment strategies to address some of the things that you may be having difficulties with to engage in those activities. We're also a multi-system approach. We're the evaluation that we conduct. We're looking at sensation, neuromotor functioning, which is basically movement, strength, balance, coordination, visual, perceptual, and vestibular systems, as well as cognitive functioning. An area that's often overlooked in the rehab process is the psychosocial or psychological, emotional, spiritual, and even familial challenges that can present as barriers to participation and to overall function in all the activities that you may engage in on a day-to-day basis. So neurological rehabilitation, so research has really been talking about what's called neuroplasticity. And neuroplasticity is basically a reorganization of the neurons, a rewiring of neural connections following a neurological incident. The theory promotes both structural and functional changes by way of motor recovery strategies, and rehabilitation. It also breaks down further into some more technical things, being homeostatic and Hebbian neuroplasticity. So basically, when things happen, an event happens, whether it's major or minor, the body is always trying to return to a sense of normalcy or homeostasis. And so it's no different in a neurological incident. So in homeostatic plasticity, the body is trying to naturally kind of reset itself and make those connections happen if they're available again. Now, timing is a tricky factor because we have to consider when the event occurred, the severity of it, the region that it was located. Where we come in is more of the Hebbian principle, or Hebb's law, which basically states that if there's a wire, there's a way, or neurons that fire together wire together. Also, neurons that fail to link fail to sync. So we're looking at those areas of the brain to recruit and to make movement, sensation, and overall function happen again. So these principles are activity-driven and dependent, and are most effective when integrating the peripheral system away from kind of the brain and the central nervous system. As I alluded to earlier, timing is very important, as is a level of intensity. There's not a one-size-fits-all strategy. This is very individualized to each patient, and we will take into consideration all the factors. We will design a treatment program that's right for you and the type of injury that you've incurred. Something else I didn't include in it is oftentimes compensatory strategies are included in the treatment plan. So they can be in conjunction with these more specialized neurological treatment strategies, as well as just being able to learn how to function again. So we use adaptive strategies, say we call a hemi-dressing technique. So learning how to dress with one hand again, or learning how to walk with an assisted device or transfer with an assisted device. As I said earlier, repetition of functional movement patterns is very important. And that can also be facilitated by modalities such as neuromuscular electrical stimulation and other modalities that we use in the clinic.
So let's talk a little bit about speech pathology, or speech therapy, as some may call it, what our practice is and what our roles are. So our outpatient therapists are all inpatient therapists at this hospital. You may have seen them while you were here in your acute stay at the hospital. You might have had an evaluation, some treatment, and now you're looking to get some more therapy after you go home. You can come back and see that same therapist or another one that you might have seen in the hospital that will provide you services that treat and diagnose the following: swallowing, language, voice, cognition disorders. So what are some of those speech and language and cognitive and voice evaluation disorders, and what do they cover in those evaluations? There's something called expressive and receptive language. So expressive language is the language we use to communicate to our family and friends. Receptive language is understanding the language that's being spoken to us. Some people might have a stroke and experience expressive or receptive language impairment, and some maybe experience both at the same time. So our job is to assess the severity and type of language impairment that's going on, and to work with you on functional rehabilitation to return to your baseline function. Some people might experience a cognitive or a memory impairment after having a neurological injury. So that might look like attention deficits, judgment, insight, problem solving, reasoning, and orientation impairments. And then there's speech. So how fluent is your speech? What's your articulation like? How is your voice after the stroke or with another neurological impairment? So what we would do is we perform a appropriate assessment. We have a whole variety of evidence-based assessments with standardized testing results, and we devise a treatment plan with you, something that's functional. We initiate appropriate and functional therapy via evidence-based practice, and we can do that in CMH or at home from telehealth. We provide patients with functional means of communication. We encourage your spouses to come in, your significant others. We provide some strategies for communicating at home, at work, and we use all functional activities for your comfort. So when would you consider being appropriate for a speech, language, cognitive, or voice evaluation? So if you're experiencing increased confusion, decreased speech output, reduced vocal quality or vocal loudness, your voice just doesn't sound the same anymore, slurred speech, multiple falls due to unsafe behavior, if you're having difficulty with judgment and it's causing falls, or you can't recall where things once were, if you're having poor safety awareness, difficulty driving, operating a car, making decisions, difficulty recalling names of people or things that are not typical for age-related difficulties. Difficulties understanding directions being spoken to you, recalling those directions, poor awareness of your deficits. You say, well, a lot of people notice that this is going on with me. I'm not sure I notice it, but I've been told this is happening. Are you having difficulty paying attention while speaking? And are you experiencing garbled speech that doesn't make any sense? So when we compose an individualized therapy program, we help to manage what's going on in your life. Are you having difficulty composing emails? Are you having difficulty speaking on the phone? Are you having difficulty ordering at a restaurant? We'll try to incorporate something that's very specific and functional to your life in our daily sessions. So we'll implement a treatment plan. We're trying to prolong function. So swallowing impairments, cognition, communication, we want you to sustain your goals and your level of ability as long as possible. We're working on patient and family education. There's a lot to learn. So our sessions will include you and your family or significant other being educated so that we're all on the same treatment plan. We want to regain the function that you once had and return to baseline. And we also, most importantly, want to improve quality of life.
So now that you know a little bit more about what we do individually, we want to talk more about our neuro rehab team and a few of the major neurological diagnoses that we treat. So the neuro rehab team is a new program offered from CMH Outpatient Rehab, and it's a multidisciplinary approach between physical therapy, occupational therapy, and speech therapy. So we specialize in all neurological diagnoses such as stroke, traumatic brain injury and concussion, Parkinson's disease, spinal cord injuries, impaired balance and falls, Guillain-Barré, multiple sclerosis, vestibular disorders such as vertigo, and visual perceptual impairments. Additionally, speech therapy has a couple more specialties, including head and neck cancer, voice disorders, ALS or Lou Gehrig's disease, dementia, myasthenia gravis, and subdural hematoma. So having this program allows the three disciplines to work together and really give a lot of continuity of care. This starts from the inpatient to the outpatient setting. So we see people in the acute stage up in the hospital, and you're able to come see some of these same therapists in the outpatient setting. So we know where you started, what your goals might be, and how you're progressing. We also offer more continuity of care between the disciplines. So there's a lot of communication between PT, OT, and speech. We're able to come together and really apply appropriate goals for patients, and it gives people a lot better progression through their therapy. Also, CMH is a certified stroke center. So we do offer some very proficient stroke rehab. So CVA or a stroke can result in impaired balance and gait, vision and perception, speech and language, eating and swallowing, memory and cognition, and just abilities to perform activities of daily living and self-care, like taking a shower or making a meal, or just getting from one area of the home to the other. You can also experience some impaired strength, movement, and sensation. So, as a certified stroke center, we can now offer a referral to the Neuro Rehab team. So again, this allows you to work with some of the same therapists that you might see in the inpatient setting. And this continuity of care really results in improved outcomes for the patient. There is improved patient compliance because these people, we already have formed a relationship with them. So you might feel more comfortable coming to someone that you've already met. There's also higher patient satisfaction, and healthcare received is more cost effective. Less time and less money for the patient, less travel time, getting different referrals from doctors in order to get the therapy that's needed. So clear communication equals better patient care. So our neuro rehab team really allows each therapy discipline to determine if additional services might be beneficial for the patient. For instance, if I have a patient that was only referred to physical therapy, I might see them and be like, wow, they would really benefit from seeing a speech therapist for some cognitive or some vocal issues that they're having, and maybe they're having trouble with some fine motor stuff too. So I really want them to see occupational therapy. So I can go ahead and make those referrals happen, saving time and money for the patient. So we can expedite referrals if needed. And as we co-treat, we're going to get more efficient progress towards patient goals. And I think this is really the most important part of this new program, is how closely we're able to work together. You might be seeing me and Scott at the same time, so we can really kind of focus in on the impairments and work towards those goals that are going to be so important for each patient.
It might seem really taxing to try to go to all three therapies in one day. It's overwhelming, but when we all can work together, we can divide and conquer and work together towards some goals and reduce the amount of repetition and the time you have to come back, so that we can co-treat together to get those goals met.
So another program we do offer at CMH Outpatient Rehab is specialized treatment for Parkinson's disease. So just a little bit about Parkinson's. It is a progressive neurological disorder that's characterized by a number of motor and non-motor symptoms. Some of the 4 cardinal signs, like the biggest things you might see with Parkinson's disease, include a tremor at rest, rigidity, akinesia or bradykinesia, which is basically slow movement, and postural instability. So maybe a stooped posture or, imbalance that may or may not be leading to falls. So some secondary motor symptoms that you might see are dysphagia or difficulty swallowing. That's where speech therapy would come in. Micrographia, which is small handwriting, which would be more in the realm of OT. Shuffling gait, festination, freezing, dystonias, which means involuntary movements. Dysarthria, which is difficulty speaking, and hypomimia, which is a quiet voice. So every person with Parkinson's presents very differently. So impairments are evaluated in the context of each individual's needs and goals. So even if, two people with Parkinson's are there for the same diagnoses, their treatment may look very different. So what we do offer here are physical and speech therapists with special certifications for treating Parkinson's disease. So this program that we're talking about is LSVT Loud and LSVT Big, which is through the LSVT Global company. So these programs are based on strategies for neuroplasticity and brain recalibration. So it's a standardized treatment protocol, and it's customized to the unique goals of each patient. It includes both gross and fine motor components, and each program can be modified and progressed as appropriate for the patient. So say they're having a lot of balance issues or they're very weak and they need to be seated because they can't perform anything standing, then we're able to accommodate that. If they're at a higher level, then we can do more with them, and more independently.
LSVT Loud. LSVT stands for Lee Silverman Voice Therapy, and it's the first speech treatment with level 1 evidence and established efficacy for treating voice and speech disorders in people with Parkinson's disease, with application to other neurological disorders. The LSVT programs have been developed and scientifically researched over the past 25 years with funding from the National Institutes of Health. LSVT Loud outcomes data has been published in a series of referred articles in speech, otolaryngology, and neurology journals. So we have 2 speech language pathologists at CMH that provide LSVT services as our outpatient services menu. And we have documented improved impact on functioning, including you can obtain increased vocal loudness, improved articulation and speech intelligibility, which is the ability to be understood by others, improved intonation, improvements in facial expression, which is a big part of communication, and changes in neural functioning related to speech and voice. So the benefits of receiving LSVT Loud therapy. LSVT Loud helps you speak with a voice and volume that's easy for others to hear and understand. Many times people with Parkinson's have a very low monotone voice. It's really hard for the listener to understand and hear them, but the perception of the person with Parkinson's disease is that they're unaware of this. So LSVT Loud helps to improve that communication. And it's built on tailored exercises that strengthen the voice box, which is your larynx, and your speech system. And the main focus of the treatment is to speak loud. So you're thinking loud and speaking loud. However, it doesn't teach you to shout. It restrains the feedback mismatch that Parkinson disorders often causes, which helps you develop and become comfortable with a voice that you can use without strain. So it's authentic to you. The loudness, you'll know, sounds normal to friends and family. So what you're perceiving to might maybe be a little additional loudness, it's normal to the listener that you're speaking with.
So the physical side of the program is called LSVT BIG. So it's an intensive amplitude-based approach, which is developed from the principles of LSVT Loud. So basically they saw how effective LSVT Loud was for helping with voice volume and everything that Dina was talking about, and they applied it to physicality. So they have documented improved readings on tests of motor functioning, which includes faster gait, longer stride length, improved balance, improved trunk rotation, which is a big component of walking, improvements in activities of daily living, such as bed mobility, and improved UPDRS motor score, which is basically just an outcome measure for Parkinson's specifically. So because LSVT BIG treatment is customized to each person's specific needs and goals, it can be very helpful regardless of the stage of the disease or the patient's condition. But the earlier you start this program, the more beneficial it's going to be. So LSVT BIG treatment is delivered one-on-one, and again is tailored to each person's abilities and goals, so that they work towards goals that are meaningful to them. So whether that's being able to pull out a chair and sit down at the dining room table with the family, or to go golfing with coworkers, we're able to incorporate those goals and create a meaningful program for each individual. The program requires and can only be given by an LSVT BIG certified clinician, and is part of a prescribed physical or occupational therapy session. It has a holistic approach, and it addresses not only movement issues, but also takes into account those non-motor symptoms that an individual might experience, such as emotional changes and cognitive changes. It helps people to recalibrate or recognize when their movements are smaller or slower than they think. So like Dina was saying, a person might not recognize that their voice is becoming quiet, or they don't have a lot of emotion showing in their face. Same thing on the physical side of things. They may not realize that their general motions are becoming smaller. So they think they're waving in a normal manner, but it actually looks very small. So this program works to recalibrate the brain's notion of what normal movement is and should look like. Sessions are based on the most effective evidence-based strategies for learning and neuroplasticity, or the brain's ability to change. And it is designed to help people apply what they learn in treatment sessions to more comfortable, confident movements in everyday life beyond these treatment sessions. So the ideal LSVT BIG and loud protocol is 16 sessions. So you have 4 sessions consecutively during the week for 4 weeks. This also includes daily homework practice and daily carryover exercises or activities based on the individual goals. But these sessions are one-on-one for an hour with your licensed therapist.
This is for speech as well, too.
So a referral for this program would just be LSVT for Parkinson's disease, and that basically would be applicable for physical or speech therapies.
So I spoke a lot before about the speech, the language, the voice, the cognitive, the motor part of what speech therapy provides. But a lot of what we also provide is dysphagia management, which is difficulty swallowing. So our role in dysphagia management is that we would complete a clinical swallow assessment. When we do a swallow assessment, we do a lot of things, but it will actually be real food, real liquid that we observe, and we check and see how all the different phases of your swallowing and see what's going on, what you're safest for, and come up with a treatment plan. I'm going to go a little more in depth about that process just so you know what to expect. So we'll complete the swallow assessment and also decide if the assessment we did together is enough, or if we need to go a little bit further with some instrumental assessment and do something like an X-ray of your swallow live. Then we'll come up with a dysphagia therapy plan, and we'll educate and counsel you and your caregivers on what our recommendations are. And then we also might make appropriate referrals if necessary to other specialists, for example, like a GI doctor or an ear, nose, and throat doctor. So how do you know if you're appropriate for a swallow evaluation? You might experience difficulty chewing your food. You might experience coughing or choking when you're eating. You might feel a food sticking when you're swallowing. You might have limited ability to make your dinners complete, or complete breakfast, lunch, dinner, getting your nutritional needs met. You're losing weight, your wounds aren't healing, something's going on, you're not thriving. If you have significant unwanted weight loss, where is this weight going? I'm not trying to actively lose weight, but I just can't manage my normal weight. Having trouble swallowing pills, or if you're having wet, gurgly voicing with meals. So if your voice sounds a little bit underwater after you're eating and drinking. So our assessment includes taking a detailed medical history. We want to know everything that's been going on, whether you think it has something to do with your swallowing. It's all important information. Tell us when things started, what you're feeling, what specific foods cause what textures cause what. Is it liquids? Is it difficulty with solids? Is it difficulty with dry solids? Is it when you're in a different position? Is it when you're eating with somebody else? Give us all the information that you notice. We provide a cranial nerve assessment to make sure all the nerves of your face are working symmetrically and adequately to manage safe swallowing. We do an oral mechanical examination. We evaluate all phases of the swallow. There are 3. And we determine if instrumental assessment is warranted, which is that X-ray of your swallow. It's called a modified barium swallow study. We can tell a lot about your swallow based on clinical symptoms we see at the bedside or right across the table, when we're palpating, when we're listening to a few things, but sometimes we just really can't see the anatomy and physiology of what's going on inside when you're swallowing. We can't see your airway. We can't see how well it's protected when you're swallowing. So sometimes we want to further diagnose and study your swallow. So we actually have the ability to give you a modified barium swallow study where you swallow the same foods we discussed earlier, but mixed with a little bit of barium in our fluoroscopy suite. And your speech pathologist will perform this test with you, and we give you all the different viscosities of liquids, textures of foods, and we actually see what's happening when you're swallowing to make sure everything's going the right way. And if it's not, we determine the effective compensatory strategies and swallow exercises that are appropriate to help what we've found during this study. So we use this study to determine your physiology of your swallow. We're looking for the safest compensatory strategies. So some people may think, okay, someone told me that if I tuck my chin to swallow, that makes me safer. Well, we don't know that that does unless we do this swallow test. The swallow test is very important to find out if those strategies are harmful or helpful. We can't tell you to do a certain strategy unless we've actually seen it work. We determine an effective treatment plan. So we see that you have base of tongue weakness or impaired epiglottic inversion. Well, what does that mean? Well, here are some exercises we're going to teach you to improve those parts of your swallow to make it safer for you to eat. We're going to rule out silent aspiration. Aspiration is when what you're swallowing enters the wrong pipe and it goes into your airway. It could travel to your lungs and cause a pneumonia. Some people experience this happening frequently and they don't have any idea, any indication, they're not coughing. Any of us can aspirate. We can feel like we're having something to drink, we're talking while we're drinking, and something goes down the wrong way. Our body's protective reflex is to immediately cough and expel it and get it out. But some people with neurological impairments or weakness might have that happen to them. Their cough reflex is not activated, and so they're developing these upper respiratory infections and aspiration pneumonias, and they're not knowing where this is coming from. So this test would help us to identify if that's in fact happening to you. And we'll make those appropriate referrals. If we do see something happening, we might notice that maybe something's going on with your vocal cords. We might send you to an ENT to further investigate what's going on with your vocal cords because they're not closing together symmetrically to protect your airway. So I'd like to give you an example of a modified barium swallow study just so you can see what that might look like. Okay, So on one side, you might see where the person is swallowing and all the food is entering where it should go into the esophagus. And on the other side, you'll see an example of someone who is swallowing and the food's not going where it's supposed to go. It's actually going into the airway. And that's exactly what I was just talking about. We don't want that to happen. Okay, that's next.
All right. So to switch gears a little bit, we're going to talk about some vestibular disorders next. So vestibular disorders are basically those that can make people feel dizzy. There might be a central source, which could include stroke, brainstem or cerebellar lesions, Chiari malformations, multiple sclerosis, or neoplasms, or there could be a peripheral source. This could be due to benign paroxysmal positional vertigo, or what is more commonly known as BPPV, vestibular neuritis, labyrinthitis, Meniere's disease, vestibular migraine, even anxiety or cervicogenic dizziness, which is dizziness that is stemming from neck movements. Traumatic brain injury and concussion can also cause vestibular disorders, but those can affect either or a central and or peripheral component. So I'm going to talk a little bit more about benign paroxysmal positional vertigo, or BPPV, because this is one of the more common diagnoses that we see. It's the most frequent cause of vertigo. It's about 17 to 42% of cases. But unfortunately, a lot of these cases are not properly addressed, whether that's because of they're not receiving an appropriate referral, or it's just not being diagnosed. So a lot of these people go around without receiving appropriate treatment, and they're just dizzy for years, which is not a way to live. So physical therapists are trained to evaluate and treat BPPV, as well as other peripheral vestibular disorders, including vestibular hypofunction, which just means that your vestibular system or your inner ear might not be functioning as well as it might, or also dizziness stemming from central disorders. So this might include habituation or adaptation exercises, eye exercises, and balance work. So something that we have down in our outpatient rehab department, which is actually really cool, is a VisualEyes video Frenzel system. So basically it's a very fancy pair of goggles that we use to help evaluate and treat for BPPV. So we have patients put these goggles on and they have a camera inside. So as we do the testing to see if a person really is dealing with BPPV, we can see very closely what the eyes are doing. So because we can't see the inner ear, we actually look to the eyes for a movement called nystagmus, which is basically just moving side to side or with a little bit of torsion. So if we see that movement, that usually means that there is something going on with the inner ear positionally, and then we're able to appropriately treat and hopefully make the person feel a lot better, if not completely better, in just a few sessions. So having these goggles results in more accurate assessments and treatments. So it's a really great tool that we can use. So if you feel like maybe you have some vertigo, you can ask your doctor to send you to physical therapy, and all they need to do is write BPPV eval.
Okay, moving on to some visual perceptual disturbances, oftentimes with neurological conditions, whether they're acute, such as a stroke or head injury or even a concussion, or something maybe more progressive like multiple sclerosis, you can have visual perceptual disturbances. So some of those things that one might encounter are diplopia or double vision, light or motion sensitivity, fatigue, headaches and eye strain, blurry vision, or changes with your acuity or ability to read or recognize, whether it's near or distance. Difficulty scanning the environment, recognizing objects, shapes, common things such as stop signs, and the ability to fixate on something. It may evoke dizziness, it may evoke nausea, and some things like that. Another thing that we may encounter, especially with stroke, is what are called visual field cuts. They're basically, we'll say, blind spots in the visual field, and they may happen in one half of one eye. They can happen in half of each eye. It can be very troubling, and it can really limit or impair your ability to function on a daily basis. Another thing that's oftentimes associated with these disturbances are what we call an inattention or neglect, where someone might not perceive or understand one side of their body and may then neglect it. So one of the telltale signs of that is if someone, say, is eating and you look down at their plate and you notice that they've eaten just one half of their meal, that it is almost cut directly in the middle of the plate, and that the person hasn't even recognized that the other half of the plate is there or addressed that they can attend to it. So there are different strategies that we use to mitigate that. Also, problems with depth perception and postural instability all can occur after neurological incidents due to these visual perceptual disturbances. So we found, or research shows, that ocular motor dysfunction can affect up to 54% of adults in cerebrovascular accident or stroke alone. This isn't including TBI. It's also not including changes after a concussion or changes that someone may have for multiple sclerosis or any other neurological condition. So it can, like I said, it can interfere with daily activities, walking, reading, writing, texting, driving, or even sitting in a car. There's something called supermarket syndrome, where people experience they cannot tolerate the movement that's moving past them in their peripheral field. It can become quite disorienting, confusing, can make them dizzy, and even avoid social situations such as riding in a car, going to the store, and in certain situations, even when they're walking down a hallway, it can be quite noxious. So what can be done? Well, if you're an inpatient, we would address it there. But if you're coming for an outpatient visit and you've noticed that you've been having any of these symptoms, we would perform a thorough visual perceptual screening assessment. It's an assessment based on quite a few tests, and we're looking at the peripheral fields, we're looking at the acuity, we're looking at the ability to fixate on objects, to change conditions from near to far, as well as the ability to attend to the environment, to recognize objects in your environment, and to function. So some of the treatment modalities that may be a result, we provide eye exercises, potentially occlusive techniques, such as binasal occlusion or bitemporal occlusion. And these are all things that we would do while waiting for our most recommended strategy, which is referral to a neuro-optometrist or neuro-ophthalmologist. We would also focus on the postural stability, because we find that when a person finds their center or their midline, they're more able to attend to their environment and engage in activities that they like or need to do. So referral to a neurologist, neuro-optometrist is high on our list. We do provide resources for local Neuro certified, that's one of the accrediting organizations for certified practitioners. And we've begun to develop in relationships with some of these practitioners in the area. There are some right here in town, and then there are some as you move out in Thousand Oaks, Santa Barbara, and either further east and south. So something that just came up this was actually an inpatient setting, but it was one of the major symptoms that this patient was experiencing. He had a stroke, and he was having intermittent double vision, and it was really bothering him. He was not able to really engage in his environment. He was oftentimes in bed for quite some time. He found it noxious to sit up at the edge of the bed. So an in-depth visual perceptual screening was performed, and we were finding that his right eye especially was not teaming together with his left eye. So some strategies were given, some light occlusion was given to bring his right eye back into a little bit of alignment. That did help him. And we would prefer that if possible, rather than a person closing their eyes and just alternating, because that can become habitual, and it's not allowing neurological information and light into the brain. So we also worked on his postural control. He tended to be turning to the right. He rotated his head, he rotated his body to the right, so that his left eye kind of took over everything. So one of the things we did was just got him back into alignment and had him start scanning his environment and fixating on objects as he could. It's a slow process initially, but we can find oftentimes really rapid advancement and progress. The education was provided in the inpatient setting, and he was provided the referral list and some eye exercises to continue. This particular patient was going to the acute rehab setting, and it was recommended that he continue these things, follow up with the therapist in the acute rehab setting, and then seek further attention on the outpatient side. Now, if he did end up coming back to our program, so I would reassess. Me or one of the other occupational therapists would reassess his visual perceptual function and provide treatment accordingly. And we would update that treatment plan with the most effective strategies. So all of this being said, all of these impairments or limitations or things that people experience, there's a big adjustment after a neurological incident, and it can cause considerable disruptions following the incidents: loss of vocation, changes in physical and cognitive functioning, changes to your living situation. Some people have to go maybe live with a family member, some to assisted living, and in some cases even skilled nursing. There's also psychological implications that happened that we address and that we definitely take into consideration during our treatment planning, as well as the family, social, and financial upheaval that can happen. Depression, anxiety, and sleep disturbances are not uncommon after these incidents, and that is part of the treatment plan that we would provide as well. So again, part of our program development will be addressing such concerns and utilizing a collaborative approach, and the partnerships within our own system and departments, as well as branching out into the community for resources and referrals, maybe local area organizations, and then helping people kind of reassimilate into their life and into their community. And in that way, we're definitely trying to promote the vision, the mission, and the values here at CMH, which is to heal, comfort, and promote health for the communities we serve, and to be the regional integrated health system of choice for patients, physicians, payers, and employees, to be an indispensable community treasure. So if you find you're experiencing any of these things, you can ask your physician, your neurologist, or healthcare professional to prescribe or refer you to the Neuro Rehab team here at CMH in the outpatient services area. The basic prescription can even say a Neuro Rehab team consult. It can also be broken down into diagnoses or specific things such as visual perceptual impairments or vestibular impairments or swallowing, voice, language, or cognitive processing disorders. So we're here to help, and when in doubt, refer to us. Please feel free to contact us with any questions or concerns. You can reach us directly at the Rehab office, 805-948-5063. Thank you for your time, and we really appreciate you tuning in tonight.
All right, so now we're going to be addressing some of the questions that have come in from the Zoom. So our first question is, what ages of patients do you treat? Do you treat children? We have a various age range of patients that we treat, especially on the neurological side of things. It really kind of depends. You might have a younger person who is dealing with a concussion or a traumatic brain injury. Generally, folks with Parkinson's are going to be on the older side of the spectrum, so it's very variable. Next question. Do you need a referral from a physician to have a swallowing evaluation?
Yes, you do. You need a referral from the physician to have a clinical swallowing evaluation, and that's different than a modified barium swallow study evaluation. So you would need your doctor to differentiate which type of swallow evaluation you need. And as far as the children question goes, we do the modified barium swallow studies for children.
Can ocular motor dysfunctions ever be completely corrected? That is a great question. It is highly variable. It depends on the severity and location of the infarct or the insult to the brain. Certain things such as cortical blindness may not be able to be completely corrected. Therefore, we would use compensations or adaptations to the environment and strategies so that people can function in their daily lives. Other things such as double vision, they can be managed more effectively, I would say. And we have strategies as well as sending someone to a neuro-optometrist or ophthalmologist for possible inclusion of prism glasses or other corrective procedures. So can they be completely corrected? That's hard to say. I would say it's highly variable, but we were definitely up for the task.
Are family members and caregivers able to attend therapy sessions? Yes. Actually, this is often encouraged, especially if there's a family member who is helping provide care for the patient. If they're able to attend the therapy sessions, they can really see what the patient is working on in therapy and then help carry that over into home.
Many times we'll like to include some caregiver communication strategies, some things for homework, things to work on together, things to help with language and word finding and what to do to return to work, caregiving, and other things that you're doing.
Does the neuro team meet to collectively review each patient's treatment plan? So yes, actually, we do weekly meetings where we're able to kind of collaborate and discuss what we're working on with patients. And this doesn't even, necessarily confine us to those weekly meetings because we're communicating all the time. We see each other almost every day. So, I might be finishing up with a patient and they're going to be seeing Scott next for OT. So he can kind of see, what we're working on. He'll be like, oh, what did you guys do today? How is the patient doing? Is there anything that maybe we should focus on or stay away from? So absolutely.
Yeah, so there's definitely an overlap, but we try to, again, with that neuroplasticity, repetition is so important. So our overlap together as well as the home program or training with caregiver education is really important. It's really imperative for better outcomes, I think, and for just overall satisfaction and quality of life.
And a big benefit to staying within the hospital system is that we can look at the initial imaging, MRI, brain CT results, neurology reports. We can look at the goals designed at the beginning and work on updating, maintaining them, avoid reducing redundant testing. We can just completely complete the continuity of care and even consult with the doctor that you saw while you were here and consult with each other. And so it really makes it more for a collaborative experience through the whole rehab process.
How often can I expect to receive therapy services? Well, again, that kind of depends on the individual and the diagnosis. If we're talking about LSVT big and loud, that may be those 4 days a week consecutively for 4 weeks. Some people are more appropriate to be seen 2 or 3 times a week. It really depends. So when you come in for your evaluation, we're able to kind of assess the situation including, the patient's tolerance for services, and we can make that determination at that time.
Sometimes it's as little as 1 time a week, and it can be as frequently as 4 times a week.
Last question, how long is each outpatient therapy session? 30 minutes, 1 hour? Well, generally at least for physical therapy, our sessions are 45 minutes, but sometimes they are an hour. This includes vestibular assessments and those Parkinson's sessions. It also depends on the patient's tolerance. Sometimes people aren't able to tolerate 45 minutes or an hour, and then we can make it shorter just depending on what they're able to do. All right, well, thank you so much for joining us. We're really excited to bring you this program. If you have any additional questions, feel free to visit the website, cmhshealth.org. And please contact us also if you have any questions, 805-948-5063. And we hope to see you soon.
Thank you.
Good night.